All right, welcome everybody. Thank you so much for joining us today. I want to say a special welcome for this event that we're having, the Building for Digital Health 2021, hosted by MIT Hacking Medicine and in partnership with Google Cloud and supported by Apple Health. My name is Aditi Joshi, and I'll be your host and moderator for the week. I am so excited to have you here today. I want to kind of go through what the agenda will look like for the rest of the week and introduce some of the speakers. We have a star-studded cast for you. We're going to be kicking it off with Professor Rob Huckman. We'll have Dr. Amar Gupta, Laura Manley, and Colonel Merbin Carattini from the Kennedy School. And then tomorrow, we're going to have Dr. Ken Mandel from Boston Children's Health, Dr. Ricky Bloomfield from Apple, and the rest of the Apple Health team. So welcome. What I do want to remind you of is that if you did register for this hackathon and the speaker series, you should have received a Discord invite from our MIT Hacking Medicine team. What I would encourage you to do is I want to make sure that you continue the conversation there. You can ask as many questions as you want, and we'll make sure that we respond to them as much as possible. But the goal is here to make sure that we've given you the opportunity to join a community of like-minded individuals who are passionate about democratizing healthcare, one hack at a time. So without further ado, I am going to introduce you to our very first speaker, who is patiently waiting backstage. His name is Professor Rob Huckman. He's a professor at Harvard Business School, the faculty chair of the HBS Healthcare Initiative, and the unit head for technology and operations management. He currently teaches the second-year MBA program entitled Transforming Healthcare Delivery. Professor Huckman is the faculty chair of HBS's executive education program entitled Managing Healthcare Delivery. And he's also a research associate at the National Bureau of Economic Research and the co-chair of the management track of Harvard's doctoral program in health policy. And with that, let's give a warm virtual welcome to Professor Rob Huckman as he comes on to our virtual stage.
Yeah, I hope
welcome, Rob.
Welcome. Thanks. It's great to be here, Aditi. Thank you for having me. Thanks to all of you for chiming in. It's great to be here virtually with all of you. Obviously, can't do it in person at this point, but hopefully we can take the next 15 minutes or so and try to set the stage for what I know will be a great several days that you're all going to be engaged with. So Aditi asked me to kind of maybe set the stage a little bit and think about how do we set the stage for innovation in digital health, which is an area I care about deeply. But I have to admit that as an economist, an applied microeconomist, I'm probably one of the least likely on this call to actually directly innovate in digital health to try to affect the question that I'd like to look at today, which is what actually could U.S. healthcare look like after we're through the acute phase of this pandemic, whenever that may be. And this is really a perspective I have from having spent, in excess of 25 years at this point, being in hospitals, looking through hospital data, using all sources of large sample data to look at the industry, and frankly, to look at healthcare delivery more broadly. And increasingly, I've been doing a lot of my work looking at new models for care delivery and new entrants who come with it. We'll talk a little bit about that today. So a lot of what I'm going to talk about kind of came from a piece that I wrote back at the beginning of the pandemic for Harvard Business Review's online portal, which was really just, let's face it, it's speculation. I hope mildly educated speculation about what might happen as a result of this pandemic for our healthcare system. What changes have we seen? What has the pandemic revealed about both the potential limitations, but also opportunities we have in our system? And what, if anything, will actually stick once we are through, again, the acute phase of this particular pandemic? So if you'll bear with me for a minute, I'll talk a little bit about what I think we've learned from the pandemic. And the first thing is one that, for those of you who are inside of healthcare, you might disagree with me on. Maybe you agree. I don't know. But contrary to the wisdom that our healthcare system is rigid and it can't actually move and it can't do anything to quickly adjust, what we've seen in this pandemic is a massive amount of quick adjustment. Now, I'm not saying this is permanent, believe me, but I think there is at least almost a proof by example that it's possible. And so, the picture in the upper left here is one of the field hospitals. That happens to be the field hospital in Central Park in New York City. That actually is a hospital. Right? We've had ones here in Boston, which is my hometown, Boston Hope. There's ones in the UK. There's ones, pretty much any place that's got a large convention center now has the potential to have a hospital, and very quickly. We're talking about within days to put these up, to take them down, to put them back up. And that's something that should be reassuring to those of you who think that hospitals have to be these large edifice kind of buildings. Now, obviously, for the most sophisticated needs, we do need more technology thrown at them than we've got here, but this gets us somewhere. Frankly, in the upper right, if you said, well, what does a lab look like in the pandemic? Well, it looks like a parking lot with trained professionals who are actually collecting, in this case, diagnostic testing samples. Our hope is that eventually we'll also have those same things happening, and I think we've started to supply willing with vaccines. And then finally down at the bottom, one of the things that happened early on for those who follow cross-state medical practice is that we actually allowed it for a while. Now, there's some unevenness into whether that's holding with us as we get deeper in the pandemic, but many states have still got it. Others have sort of put a time delimitation on it. Maybe it'll be extended, maybe it won't. But we have finally acknowledged the fact that medicine that people study when they go through 4 years of medical school actually is applicable when you cross the border between Colorado and Kansas, or between Kansas and Nebraska. Medicine doesn't change. And that's a very important, I understand, simple realization, but one that our system has seemed to have structured without an appreciation for. So what else have we learned in this pandemic? Well, we've actually learned that telemedicine, actually, part of its name is medicine itself. It is medicine. It isn't just some, necessarily, poor substitute for in-person care. In fact, in many ways, I mean, we've seen, the standard telemedicine you see on the left, which is somebody in an office interacting with a patient, likely in their home. That's kind of what we've maybe seen telemedicine as. And for a while, our system didn't really pay for it very well. Again, during the pandemic, we sort of opened up payment for this. But not only that, we started to use telemedicine even in the confines of the inpatient setting. So you see the example on the right, that's actually somebody who's standing just outside that hospital room. And because we want to minimize the risk of infection, but we want to maintain some degree of patient contact, we've actually used this incredibly, incredibly sophisticated tool called an iPad, which I do say yes with tongue in cheek, for a purpose that actually is very basic, and it creates human contact in a way that's safe in the context of this pandemic. And what's to say that we can't do things like this with family, with others? And obviously it was done during the pandemic under much more dire circumstances, unfortunately. But nonetheless, we've proven to ourselves that we can actually make telemedicine not just simply a separate business line from hospitals and physicians, but a tool that hospitals and physicians can use to complement what they're doing. Again, that will require that payment structures continue to support this use, which is something that has also been called into question as the pandemic has gotten more mature. But I hope this will continue even after the pandemic's acute phase ends. What else have we learned here? We've learned that we've got a lot of needs in health that aren't traditional healthcare. They're social needs. And in fact, if you look at the United States and our spending on healthcare, we've always talked about how much we spend on healthcare, 16%, 18%, it's 18% of GDP, right? Much higher than many other developed countries. However, when you look at how much we spend on other social services, we're actually relatively modest. And what this pandemic has probably told us is these two things need to be seen together. Right? Investments that you make in education, in transportation, in food security, those are investments in health, just like investments in medicine, healthcare, physician care, hospital care, etc. And so it's important for us to think about, well, how can we start to think of these two needs as a single bucket? And how can we as a society think about how to most efficiently provide those? And I think the pandemic has showed us these two sets of needs coming together in very, very important ways, particularly as the pandemic has hit disadvantaged communities extremely hard, many times for social determinants reasons. What else have we learned? Well, I think the fourth lesson we've learned is that our insurance system is way out of whack. Now, I'm not saying that our insurance system had to predict this pandemic, but it needs to be able to help us as we go through it. That is, we need a system that doesn't just simply ensure healthcare, but that it actually ensures health and it ensures care. And what do I mean by that? Well, the piece on the left is just a clip from the article that I referenced early on that I wrote, which basically says we have a healthcare insurance system that it's not really built for a pandemic. But when people came to hospitals and they inundated hospitals back in the spring here in the Northeast, for example, and now we're seeing it throughout the country, we had very unique, very severe needs for these patients, which our current insurance system was not particularly well set up for, on an actuarial basis to kind of to handle. And so we have to think about how do we ensure not just for routine medical needs, but for these truly tragic moments when people, when we have a pandemic and we have very particular needs. And some of that might even be things that aren't specifically attributable to one patient. For example, if we have to entirely retrofit hospital capacity, make a hospital lobby into an inpatient unit, as many hospitals have had to do, we need to think of ways to fund that activity. And so interestingly enough, there have been some models that have started to look not just at that particular question, but at other forms of ways in which we could broaden the notion of what does it mean to insure. And in fact, Blue Cross and Blue Shield of North Carolina, their Accelerate to Value program on the right was actually an interesting model for helping to bring providers through the acute phase of this pandemic when they were losing volume left and right because people weren't going to office visits. And think about how can they move them into new models of care, which in this case would be value-based models or risk-based models in the future. And so Blue Cross and Blue Shield was kind of interested in kind of linking these two things together. So they provided support today with an understanding that in the future, these physicians would start to think about how they got compensated in more of a value-based mentality. And it's been actually a very big program for them. The final thing we've learned, I think, in this pandemic is that we've learned that a lot of companies can deliver a lot of things to us at home. Many on this call learned that a long time ago. I actually did myself, but we are seeing it in spades. And so now the question is, why not healthcare? Why can't we add healthcare into that mix? I've done a little bit of writing thinking about this from the perspective of when Amazon announced its now failed Haven venture with JP Morgan Chase and Berkshire Hathaway. I wrote a piece on what Amazon's actual kind of hooks into healthcare might look like based on their history with, say, new business opportunities that they pursued, like Amazon Web Services in the past, which were incredibly successful for the company. How might that give us some insight into what they might do in healthcare? Same thing with sort of big box retailers like Walmart and Best Buy, which have particular and unique links into how they might be thinking about healthcare in the future. And I would say just in the context of Walmart, they have a lot of retail employees who work in stores. They would love to have many of those retail employees be trained in healthcare, basic healthcare functions, so that they could now support the new Walmart health model that's developing. And it gives them both an outlet for their workforce that's in less demand as retail stores are increasingly moving online, but also moves people into perhaps a slightly higher skilled position within healthcare. Same thing for Best Buy, which is, they've long sold monitoring devices in healthcare, and they've serviced them just like they service all sorts of electronics. They've had a Geek Squad, which can come to people's homes. And what's to say that couldn't move further into kind of some basic healthcare needs? Maybe it gets paired up with a home health provider who joins your technician when they come to your house. Who knows? But I think these potentials are real, and I think we're seeing the need for them through the context of this pandemic. What might this convergence of these non-healthcare companies into healthcare look like? I think a great example is TytoCare, which some of you may know. Tyto is a device which you see in the upper right there. It basically allows a patient to put a lot of different probes onto a sensor and essentially have an otoscope, have a stethoscope, have a tongue depressor, have basic things that you would use during a primary care physician visit. And you move this around as the patient, and your provider's on the other end seeing the results. Well, Tyto needs a lot of things to make it work. First of all, it needs a provider. So in this case, Oxner in Louisiana is a company, just one of many providers that have started to use Tyto through its primary care practices. It needs some place where people can buy these things. And again, I go over to the bottom bottom left there, Best Buy is actually sells them, but so do several other places. But retailers are now brought into the mix. And then it needs some way to move this data, store it, and do everything that's required when you're running a medical system across this. And that's actually where Amazon, I think, when some say, how will Amazon have an impact in healthcare? I think this is potentially the biggest way, which is through its non-healthcare business, Amazon Web Services, which will host all of this information, move it, and document and store the record of it. You can imagine what a big deal that might be if it's brought to bear in healthcare. So it's my final slide before I head off. I just want to say, all this change is wonderful, but it doesn't mean anything if we can't get it to stick. So how might we get some of this change to stick? What could we as a system do to try to make this more permanent? One is that these regulations that I mentioned, for example, practicing across state lines, changes in scope of practice, which have allowed a lot of physicians' assistants and nurse practitioners to have broader responsibility during the pandemic. Rather than simply defaulting back to the way things were, let's cause those to be actively reinstated. Let's make sure that states and the federal government would actively have to reinstate these things rather than just let them default back to their old restrictive models. I know there's some disagreement there as to how far we should go. I actually don't think we should. I think we should leverage all of these new opportunities, but I also realize there are limits on them too. So it's not unfettered when I say we should expand, but it's that we should be thinking more broadly. Next, we need to change financial incentives for providers. We need to simply just move away from our traditional model of paying for fee for service to one based on value. That is, not the amount of care delivered, but what you actually do with it in terms of outcome and cost. And when you're talking digital health, all of digital health depends on our moving our financial model towards something that makes more sense in this way. Because without it, it's going to be an uphill battle against in-person care, which is currently paid on fee-for-service basis. Next, I think we need to rethink insurance. As I've said, we need to move from simply or insuring the routine, which is like insuring basic car maintenance, to actually insuring these unpredictable pandemic needs, which is truly about getting more towards something that feels like it actually helps us in those unpredictable events that can be quite devastating. And then finally, how do we think about these new entrants? So many of the existing players in healthcare look at the new entrants and they say, oh, they're coming here to disrupt us. We really need to buckle down and get more efficient ourselves and really try to make sure they don't kind of knock us out. Now, I agree they need to get more efficient themselves, but I'd really like to encourage existing providers to look at these new entrants, these new technologies, these new digital technologies, and say, how could they be a vendor to us? How could they be just like any large electronic medical record system for which we rely on a vendor? Perhaps we could go to Amazon. Perhaps we could go to TytoCare. Perhaps we could go to these other companies and think about ways we could work with them as partners to deliver care more effectively and leverage analytical expertise and other expertise that these organizations have in spades. So with that, I will say I am thrilled and excited about what's to come. I want to thank you for taking a little time with me, and I would love to stay in touch. I have put up 2 channels here, but just thrilled by the opportunity. So thank you, Aditi, and thanks to the group.
Thank you. We have a couple of questions in Discord. Do we have time for one question with you?
Sure.
Okay, so the question comes from Sriram. The question is, what is his opinion, Professor Huckman's opinion, the economic angle, both macro and micro, about an established marketplace for patients and subjects to be able to barter data directly with researchers and companies? And the question was actually triggered by last night's 60 Minutes program. Yeah,
that's a very interesting question, and boy, a lot longer than the time I have to answer. But I think at the heart of Sriram's question is this point about individual data being actually the property of that individual. Now, of course, many of these these medical records are actually contained in medical record systems that are housed inside of providers as we stand right now, and it becomes an organizational discussion when you talk about how that data might get used for analytical purposes. Let's be honest, most providers, the reason they got into the electronic medical record arena to the extent they did most in the last decade was because of the High Tech Act, which basically created subsidies for this, and essentially a lot of regulations said if you don't move in this direction, you're good luck getting getting your bills put through various federal programs like Medicare, et cetera. That is not the way to bring us into data and data sharing in healthcare. I think Sriram's point is a very well taken one, which is like, can we figure out a way to make consumers aware that your data is a critical and very private and personal asset, but one that you can also choose to share, just like you have the choice about organ donation and other things. Could we have the similar choice about data donation, which I think is a very interesting piece, and I think it could be such a powerful tool if we could get it done at large scale. I think the key is there's going to need to be a strong effort to convince people that it's safe to engage in these kinds of exchanges. But the power in it could be massive, because it could open up actually other sources of related data that could be really helpful to understand people's health.
Great. Thank you so much, Rob. I know we're out of time. I wish we had more time with you, but next time possibly. I'm going to move you backstage. I love reading your HBR articles. So
thanks. Thank you. Thanks, Aditi, and thanks to everybody. It's great fun.
Thank you so much.
Take care. Bye-bye.
Bye. All right. Thank you so much, Professor Huckman, for that amazing presentation. Next up, we have Dr. Amar Gupta. Dr. Amar Gupta rejoined MIT in 2015, and he's affiliated with the Computer Science and Artificial Intelligence Lab at MIT, the Department of Electrical Engineering and Computer Science, and the Institute for Medical Engineering and Sciences. Earlier at MIT, he served as director of the research program on communications policy and coordinated the establishment of the Internet Telephony Consortium that played a pivotal role in the commercialization of voice over IP technology. He also served as founding co-director of the Productivity from Information Technology Initiative and is a lead inventor of the patent on automated reading of bank checks. This concept actually resulted in the Check 21 legislation in the United States. So it is a treat to have him here as well. What I'm going to go ahead and do is I'm going to move him to the virtual stage and allow him to share his screen so that you can, there we go. Hi, Dr. Gupta.
Hi, good morning, Aditi. Thanks so much for this very generous introduction. And I wanted to thank you for taking the initiative. You're the sole person who got this whole event moving. I also want to thank all the participants who are attending this session. That's a record number in itself. And I also want to take the opportunity to thank Jessica, Julia, Stephanie, and others from the MIT Hacking Medicine for putting this all together. So let's start with the discussion. The first thing I'd like to say to everyone is that what I'm presenting has been done by a lot of people, both inside MIT as well as outside MIT, including, which may seem surprising to the previous speaker, Professor Huckman, Nitin Noria, who was the dean of the Harvard Business School until very recently. He actually worked on something which I'll mention briefly during one summer when he was a doctoral student at MIT. So we have had a lot of connections with Harvard and a number of other places. The second thing I'd like you to think about is that if we think of telemedicine in terms of innovation, until recently, until prior to the stage when COVID came in, Massachusetts was among the top states in terms of innovation. If we take the top 10% of the states of the US, the top 5 of them. And in terms of deployment of telemedicine, Massachusetts was in the lowest category. It was in the bottom 5 states of the country. So one starts thinking, what is the reason for this dichotomy which takes place? And this is one of the issues I'm going to take up. And the most advanced states in telemedicine until COVID took place were Alaska, Arizona, and Hawaii. And one would think, well, it's because of the distance which is involved, that people are in rural areas. That is not the real reason. The real reason is that in these states, the people in technology, the people in medicine, the people in law, the people in computers, the people in engineering, the people in policy, at universities there, they actually work together to make it work. And that was the key reason why these states have succeeded. Whereas in the other states, they're doing things in these different fiefdoms, if I may use that term, but they're not really working well with each other And that has been one of the biggest stumbling blocks. And that's one of the reasons why foreign countries are ahead of the US. And in the US, the Western half is much more advanced than the eastern half of the country. So I'm going to come to this issue a little later with specific examples, but I wanted you to think about this. But I also, in addition to it, want you to think about two other issues. And again, if you have any strong feelings or you think you know the right answer, you can convey to others through the mechanism that you have, the Discord mechanism. The first issue I'd like you to think about is what was the first place in the world that telemedicine was adopted, specifically the country, the state, and the place, and roughly in what year this thing took place. You can, as a time thing, you can start from the time when the telephone was first introduced, how many years after that it actually took place, or whether it was 50 years, 100 years, whatever number you want to come up. So feel free to have an exchange on it. And the second issue I'd like you to think about is in the US, which is the first place where the government got involved in healthcare activities. Prior to that, it was all done in a totally the patient to the practitioner kind of a way. How did the government get involved in it? What was the motivation for it? So those are the issues I'd like you to think about. And somewhere in the middle, I'm going to come back and ask you and react to these things. So as we just heard, COVID-19 has acted as a major catalyst for telemedicine, and it has done what many people who have tried for the last 10, 15 years, 20 years were not able to do it. And this kind of forces which try to favor the status quo, the people who are benefiting from the status quo, they want that thing to stay. The people who are going to be helped by the new forces, the new mechanisms, they are not there to help do it. And this is called the Machiavellian forces, which is the forces of status quo. So COVID-19 has done a very major job in terms of trying to get this thing moving. This has not happened for the first time. In recent years, if we take Y2K is an area, prior to that, it was very difficult for companies to be motivated to do work abroad. I remember going in the 90s to Swiss banks, and they absolutely thought it was ridiculous at that point that work will be done from abroad or people from abroad will be coming and helping out. All these banks used to operate there, and Y2K and the European move to a single currency, the euro, that changed a lot of dynamics there, made industries much more competitive, and we all benefit from it. On one side, yes, jobs are lost in countries. On the other side, people get lower prices for it. They don't realize that some of these lower prices are occurring because some of this work is being done in lower priced countries for us. Another area is 9/11. It played the major catalyst role for the adoption of the automated techniques, the first major industry which adopted worldwide the concept of artificial intelligence, neural networks, and others. And I'll come to that in a moment. The financial industry and the healthcare industries have a lot of similarities in terms of cost, in terms of security issues, in terms of privacy, in terms of turnaround times, in terms of quality, in terms of safety. So in order to understand what could be lasting in the healthcare industry, it might be appropriate to start with the financial industry and say what happened there, why it happened there, and how we can leverage this to think about long-term change and reform in the healthcare industry. So in the healthcare industry in the US, banks were only allowed to operate in one state of the country. So Citibank, for example, operated in New York State, Bank of America operated in California State. And originally it worked fine that the depositor was there, the bank was there, but the first thing which threw it off was the introduction of bank checks. And the government could have allowed the banks to open branches in other states to allow these checks to be processed, but that's not what the government did. The government said that anytime a check is out of state, the government itself took the responsibility for getting the checks cleared. So for 8 years, I spent my summers at MIT, my winters in Arizona. If I used a Boston checkbook to write a check in Arizona and gave it to a dealer, the dealer in Tucson would give it to the bank, and the bank would be read by two people to make sure it was read properly. Then the amount of the check would be put at the bottom of the check where the line is there showing the account number. Then it would go on a truck to the designated branch of the Federal Reserve Board, which happens to be in Sacramento, California. Every day, every check had to go from Arizona to Sacramento. Then it would go by an air courier to Boston, then to the lead bank, then to the local bank, and then given back to me as a check. So in this manner, about 44 billion checks were processed each year. The cost of processing one bank check was $1.25. So that's the amount of money which was being spent alone in the US alone to process these checks. So again, destiny has played a major role in my life. It was total destiny that I got involved in this project, started looking at how this amount on a check could be read properly, quickly, accurately. And in the US, there were a lot of issues which constrained it. In the US, people write cents in about 25 different ways. It's very difficult to read the cents properly automatically. My students proposed that the cents portion should be disregarded. We should use automated technology. The banks would not accept it. We started looking at checks in other countries. In Britain, the pence and the pounds are written in the same size, but in Britain, the check had to be in written form. It did not say had to be in paper. So there's a real example of a person who wrote a check on the side of a sheep, took the sheep to the bank, and the bank had to honor the check because it was in written form. So we looked at these things. We came up with new technologies, new methodologies using artificial neural network. We started with a small country in Asia where we first deployed our ideas. Then Britain got interested. We came up with specifications. Within a few months, they were ratified. But in the US, nobody was interested in it when we started doing this work because the forces of status quo maintained what was there. They did not want to change it. And the only reason it got adopted and sudden reason why it got adopted is because of 9/11, because all the planes were grounded, the checks could not move. And within a few days, $50 billion worth of checks got stuck in the system. So instead of declaring financial bankruptcy at multiple levels, the government introduced emergency laws to say that the image of the check should be used instead of the physical check. And that's what really played a major role. So I'm giving this as an example and to say how these things have a ripple effect. And this technology which is there, it was very helpful. Our work which was there, again, a lot of students worked on it. And initially, they were very reluctant why I'm putting it in the public domain. And I used to tell them that some things are more important than money. You should think whether you left the world a better place than you came in. And one of them later did use this whole method to do things for free for the society. His name is Salman Khan, and he started Khan Academy. He was one of the persons who worked several years on this project. We took this idea and tried to apply it to the healthcare area, came up with it, doing it for the area of mammography, tried to do it. It was too early, 2000, 2001. Nobody took interest in it. There were all kinds of constraints. Who will pay for the service? Nobody is going to pay. And because nobody was going to pay, nobody took interest further on it. It did win the first prize in the venture capital contest at Cornell University. It won the second prize at Harvard University's contest, but it didn't go anywhere. We went back to the research environment with several renowned doctors. We came up with an approach called the three-pronged approach to healthcare, that all healthcare over time is going to use three prongs: on-site personnel, nurse, technician, family member; off-site personnel, maybe in another city, maybe in another state, another country, who's the domain expert for this area. And the third point was computer-based techniques and processes. And we defined telemedicine that anything which uses any of these two prongs is in the category of telemedicine. So by our definition, everything that you see around in digital health and all will fall under the category of telemedicine. What happens next is that when I was in Arizona, I was fascinated, or I was touched by an incident where a car accident took place in Mexico. 6 adults died on the spot. One baby arrives in a remote clinic in Arizona. The doctor on duties knew it's her first day on the job. She did not know what to do, but in Arizona, they have a very good teletrauma network by which people in remote clinics can consult the doctors in trauma situations in the cities in Tucson and in Phoenix. And using that, the child's life was saved. And today, these chances of survival in trauma incidents is 50% in the rural areas as compared to in the urban areas. So I talked to the doctors who had done this surgery, very impressed by them, said that you've set up a great example for the nation. And they looked at me with a very funny look and said, we can only do it for Arizona. We are not allowed to do it across the state. And I was totally puzzled at that time what was going on, went to the literature and found a case where Roche Pharmaceuticals started a new company called for this kind of work. And it was very successful. But it was seeing the company had doctors in Indiana looking after patients in Illinois. But within a few years, the company had to shut down because the people in Illinois said what they were doing was illegal and would not allow it. So that motivated me to think about what should be done. why is the government even involved in healthcare? Where did telemedicine originally emerge? So to answer your questions, which I raised at the beginning, the first place where in the US the government got involved in healthcare is the city of New Haven, where people were coming on the boat from Europe. They were contracting yellow fever. The city said, we have the right to put you in quarantine. We have the right to force you to take medicine. It was done under the doctrine of public safety. We want you to be safe and alive. And that was the basis under which it was done. And in terms of where telemedicine was first applied, when Alexander Graham Bell came up with the notion of telephone, and he was on the Boston side. He had an assistant of his in Cambridge on Main Street within half a kilometer of MIT. And the assistant is the one who spilled some acid. And Alexander Graham Bell gave him advice on what he should do in order to take care of the acid and the injury to him. So that is the first recorded incident of telemedicine, the same year when the patent for the telemedicine was done. But in reality, we see today, after that, there have been a lot of restrictions which have been imposed. The laws have been enacted by state governments saying that only the people within the states can look after it, cannot be done. So we went ahead, and this, again, I would say is destiny, that a few years earlier I had gone through the immigration process to get US citizenship, and I had to learn US laws or US concepts. And there I learned that all interstate regulations can only be done by the federal governments, not by the state government. So I was intrigued. I had a JD student work with me on this, and we wrote a very controversial paper in a law journal in 2010, saying that all the restrictions imposed by state governments on interstate practice of telemedicine, they violate the Interstate Commerce Clause of the US Constitution, and therefore all these laws are illegal and inapplicable. It took 7 years for the Department of Veterans Affairs to come up with a policy which essentially embraced this concept of disregarding state regulations altogether. And more than that, what has happened this year, in the last year, because of COVID, a lot of these restrictions have been taken away. But it took a calamity like this, and it took people to really force the issue to really make it work. And the question one asks is, why couldn't this be done before? What is happening now? We have done it at a national level. What is happening at an international level? In many other countries, people do it across state country boundaries. When will this happen in the US, or should it happen into the US? So these are some of the questions which you raise, these issues which we are talking about. So now the Department of Veterans Affairs, I should tell you, is prior to this enactment of this new regulations, they were spending $1 billion a year just on the transportation costs of people coming and going to hospitals, not for anything else, not for the treatment itself, but it was only on the transportation cost. That was the figure that they were incurring. So imagine how much savings they would have by this method. So when this came in, our group got a lot of good messages from people complimenting us on our work. But we also got some adverse reactions. And one of the reactions I got was from my own colleague in my own building at MIT, telling me that why did I waste my paper writing a paper on a subject like this? A lawyer could have done it in 1 hour or 2 hours. And so that's the kind of reaction I get. 2 weeks later, I'm at Yale University, same place where I said the government got first involved in healthcare. And I ran into a doctor who was also a lawyer, and I talked to him about interdisciplinary work. And he says, yeah, we should do interdisciplinary work. More of it is required. And yes, doctors should know about law. And I said, what do you feel about computers and information technology? He said, no, we don't need those people. Even a high school student can write a program these days. Why do we need those computer people to be involved in these things? So this is one of the major impediments that I find in this place, that we do super wonderful work in our respective domains, but the lack of courtesy that we have for taking into account the other people's views, that has been a major impediment when I see the US situation with respect to other countries. In the case, in the recent year also, I've seen the economists will basically say that when a person comes to a hospital for COVID, disregard the previous records altogether. That's just a waste of time, and I'll just focus on it. That will reduce cost to be involved. Doctors, on the other hand, will say we are only given 1 or 2 masks a day. The mask is the most important thing. The mechanical engineers will look at the ventilators. But the synergy between the different things is just lacking. So that's one of the areas where I think the US has been in a different situation with some of the other countries, which have done a much better job with coordinating the effort. The second area is, again, a very difficult one to talk about. It is that a husband was getting a good job in LA as an endowed professor. The husband and the wife had gone there to look at houses. The wife has a fall at a prominent hotel there, is taken by the city ambulance to a prominent hospital there, and at the hospital they say that we only take care of our own patients even in emergencies, and they spend next 4 or 5 hours trying to send to another hospital, and none of the other hospitals would take it because it's a violation of federal law, state law, and local law. And when they couldn't find another hospital to do it, they told the patients to fly 2,000 miles back to Boston to get the emergency surgery done, which was done 10 days later, 4.5 hours long, put plates and pins in it. And after that, the lady is having medical problems because of the delayed surgery. That's what was told. And this hospital group has done it in the past. And by the way, I should tell you that this particular incident has happened to me and my wife. So I'm telling you that today when I read about LA having much higher rates of COVID, maybe this is the reason why they are having more higher rates of it. Maybe it's the reason that in California, only you can file lawsuits for 1 year, and it has the most liberal laws in terms of giving freedom to the doctors and others, and the most restrictive laws as far as the patient rights are concerned. So these are some of the things which also which act as forces in situations, whether it is COVID or otherwise, and we should think about these issues as well as we go along. At a global level, I should take that there's statistics which is available of all kinds. Age longevity in terms of the number of children who die before it, and it's published by World Health Organization, it's published by Central Intelligence Agency, it's published by others. And US is generally rated around 50th or 60th in the world on this rating scale. Here it's this is the number of children who die. And in terms of the cost on a per capita basis, the US is the highest. In terms of quality, we are around 50th or 60th in the US. So again, this is the same kind of repeat of the situation of the financial industry. We can either continue to do the way we have been operating and have higher costs, which will make our goods and services more competitive in a truly globalized way, or we try to find better mechanisms of dealing with the healthcare area. So these are some things for you to think about as we think about what can be done now, what can be done in the future, the zeal that you have for making change to the world. Think about these issues as you go along. Now, when we come to a whole society dealing with healthcare, digital healthcare, based on our earlier work in other fields of the economy, we like to think of it as 4 different building blocks that one should think about. One is the knowledge acquisition part, the knowledge discovery part, the knowledge management part, and the knowledge dissemination part from a society's point of view. Knowledge acquisition is a thing where I think Google has done a good job in terms of taking information from a lot of places, making it accessible to a lot of people. The problem we have, however, is that when we look at the literature, we get a lot of conflicting views which are expressed on the net. Here is an example from nutrition where different people are saying different things, and you can find other articles which are there. And so there's a lot of contradiction between it. And in the coronavirus case, pandemic, again, you'll see all kinds of information coming in. So how do we really extract real knowledge from it? How can we do things which are reproducible? How can we do things in a manner which can be applied across different kinds of population, different kind of age groups, different kind of medical conditions? Drugs, for example, are generally done on the basis all drugs are testing as if a person is only taking one drug at a time. In reality, very few people in the world take only one medicine at a time. What is the reaction between these kind of things? So these are the kind of things where, with the kind of technology which is available today, we have the ability to get more of this analysis done and to do it. But this has to be done if we have to really come up with solutions, automated solutions and others, where we can really use digital technology in a much better way. Second area is this area of knowledge discovery, which is that given a lot of data, can we find any trends in it? Can we find any new insights in it, especially insights which a human being cannot do? Human beings are good when the number of dimensions are limited, but when we have 80 or 90 variables, that's very difficult to do it. So that's a difficult way to do it. The third area is this notion of how do you take this thing. 2 of the ventures which have come out from my group recently are the Bloomer Tech, a bra which a lady can wear to work, and another one is for teeth. The third area is the interoperability area, which will be which you hear about all the time. The mismatch between the information, the problems involved in getting information from different sources on it. And here again, There's a very interesting article which is written which puts 50% of the blame on information blocking on the EHR companies themselves, and 25% on hospitals, 25% on others. And therefore, we need some better ways to deal with this interoperability aspect in order to go and address these issues in terms of doing this thing on a country basis or on a global basis. The fourth area which we should think about is this area of knowledge dissemination. People claim that, doctors especially claim that there's so much extra information which is coming in. There's a question of information glut. How do we know what to do it? And earlier in the area of information integration, after the Grenada War, where the soldiers in the field could not talk to the pilots in the air, we played a role in terms of coming out with new procedures for for integration of heterogeneous information systems. And at that time, one of the generals told me that on a bombing mission, we give the least amount of information to the pilot. Now, here in the medical case, what do we do as far as getting this information? How can we compress it? How can we give less information which is required? So that's an area where much more information is required. We need feedback from patients, patient-reported outcomes, who should take care of it, who should be responsible for authenticating technologies which would be done. A lot of these things, there is no peer review process for it. There is no real process on a global basis in order to have quality control in these areas. So these are 4 areas where we have to think about as a society, who's going to take the lead on it, who's going to work on these areas, who's going to do it. And these are areas which, as you look forward in your careers, you should think about what role you can play and how you can play this role in it. Also, originally we were talking of things at a village level. I talked about this issue of interstate regulations. We need to think about the same issues in terms of country regulations. The devices which we are coming up, the national borders do not make any sense on it. In these areas, we need really global approaches to it in terms of regulations, in terms of quality controls, in terms of getting feedback. And there are previous examples where things which were done at a local level, at a state level, subsequently went on the international level. So that's again another thought area which needs to be done. So when we look at laws, the countries where I found the best laws with respect to telemedicine are Malaysia and Australia. And in terms of the interoperability of crisis, this is an article in Fortune magazine which has come in. There are 175 different interoperability initiatives going on around the world. There is a lot of heterogeneity. There is also no definition on who owns the ownership to the data. Only the state of New Hampshire clearly defines it in the US that the patient owns rights to the data. Other states have left the thing undefined on it. And therefore, there's confusion whether the EHR companies own it or whether the hospitals own it and what rights the patients have to do it. So the things, I realize I'm running out of time here and I'm going to end pretty soon. We had also proposed the idea of doing telemedicine across countries. And I should tell you that Emory University has now taken a situation where some of their doctors and nurses are working in Australia during daytime to look after patients at night in the US. So that this is synchronous telemedicine that we're talking about. People are using it in rural areas, disadvantaged areas. When we talk of interoperability, we are not just talking of EHR records. We are talking of a lot of other areas as well, which are in the ecosystem, the pharmacist area, the opioid areas and others. And then the main issue which I want to emphasize is that we need to work concurrently on strategy, technical, medical, business, and legal issues to move forward. Thank you very much.
Thank you so much, Dr. Gupta. The Discord channel is actually lighting up with us with several questions. I know you are on the Discord channel, so let's make sure that we continue the conversation over there. What I'm going to do is we have to keep moving. Let me introduce you to Laura Manley, but before that, I do want to say thank you to Dr. Amar Gupta, who really has been very, very helpful and supportive over the last few weeks. So thank you, Dr. Gupta, for that help and that support. We couldn't have done it without you. I want to introduce you to Laura Manley, who is the director of the Technology and Public Purpose Project at Harvard Kennedy School, Belfer Center. She has also testified twice to Congress on her research to improve science and technology expertise in government. Previously, Laura co-founded the Center for Open Data Enterprise in Washington, D.C., which is a nonpartisan research organization that works with governments to leverage data for social and economic good. She's also an adjunct professor at NYU School of Public Policy, where she teaches data for social innovation, as well as being an instructor at the Harvard University Extension School, teaching data-driven decision-making for business leaders. And she serves as senior consultant for the World Bank Group and the United States Department for Economic and Social Affairs. I also have another speaker for you, Colonel Mayor Caratini. And Mayor Caratini is a National Security Fellow at Harvard Kennedy School. His previous assignment was serving as the Senior Medical Planner and Assistant Executive Officer to the Army Surgeon General. Before Battalion Command, he was the Executive Officer to the Deputy Commanding General for Operations, U.S. Army Medical Command at the Joint Base in San Antonio, Texas. And he was Chief of Commanding General's Strategy and Innovations Group in the U.S. Army Regional Health Command Pacific Region. He also had duties to Command Surgeon for the U.S. Army Pacific and the 18th Chief of the U.S. Army Medical Service Corps. And on a side note, I had the pleasure of being one of Mayor's classmates at the Kennedy School. So with that introduction, let's welcome both Laura and Mayor to this virtual stage. Thank you so much for being here with us today. Can you hear me okay?
Yeah, I can hear you just fine.
Let me get us to the next slide. Give me a second. There you go.
All right, Aditi, just let me know when you'd like me to kick off.
All right, it's all you.
Okay, all right. Well, thank you for having me. I'm really thrilled to be participating in this conference. As Aditi mentioned, my name is Laura Manley, and I'm the director of the Technology and Public Purpose Project based at the Harvard Kennedy School Belfer Center for Science and International Affairs. Our mission is to ensure that emerging technologies are developed and managed in ways that protect the public good. But prior to my work in tech and public good, I actually worked in mental health for nearly 10 years, and we can move to the next slide, please. And the next slide. Great. For nearly 10 years, I focused on advocacy and destigmatizing efforts for people with mental illness and developmental disabilities. I worked primarily with the National Alliance on Mental Illness, which is the nation's largest grassroots mental health organization dedicated to building better lives for millions of Americans with mental illness. With NAMI, I developed a mental health awareness curriculum for high-risk teens in Indigenous communities. All right, next slide, please. Okay, so to kick off our conversation today, I'd like to just take a moment. Think about a time when you felt alone, a time when you've been so anxious and overwhelmed that you couldn't sleep. Think about a time when you felt like nothing was going your way, where you struggled to see how things could get better. It can be really dark and lonely getting stuck in these places, and unfortunately, millions of people experience this every single day. Next slide, please. In fact, 1 in 4 people in the world are affected by mental health disorders. And given the overwhelming stigma around mental health, I actually think this figure is much higher. Anxiety, depression, bipolar, OCD, and other conditions are some of the most common things that people experience, and they're more common than people realize. Next slide, please. And now with the global pandemic, mental health for millions of people has been absolutely devastated. Illness or fear of illness, social isolation, economic insecurity, disruptions of our regular routines, and the loss of loved ones are known risks for depression, anxiety, and obsessive compulsive disorder. And those experiences have unfortunately been our lived reality for much of 2020 and into 2021. According to the CDC, reported anxiety and depression has quadrupled as of August 2020 compared to a 2019 US sample. We are in a once-in-a-century type of moment here. The whole world is experiencing a collective trauma. So one of the few silver linings of this moment is that more people are talking about their mental health, and we're starting to normalize the conversation. Next slide, please. With the slow destigmatization of mental health and increase in demand for coping skills and strategies, we have a new opportunity. Tech has opened a new frontier of mental health support. We have mobile devices like cell phones, smartphones, and tablets, giving the public, doctors, and researchers new ways to access help, monitor progress, and increase understanding of mental well-being. All right, let's jump into current trends. There's been huge excitement about the range of opportunities to address mental health awareness, and it's led to a burst of app development and new content generation. As of 2019, there were over 20,000 mental health apps available in the iTunes and Android app stores, and the number is growing every single year. In the past several years, we've seen an increase in 4 types of apps and content covering mindfulness and meditation, general mental health and wellness, specific types of mental illnesses, and suicide prevention. The industry has gotten quite creative in delivery models as well. You can find everything from mobile and desktop applications to wearables and short-form video content on social media like TikTok, Snapchat, and Facebook, and digital support groups. However, this new tech frontier includes a lot of uncertainty. There's very little industry regulation and even less information on app effectiveness, which can lead people to wonder what information should they trust. With all this in mind, let's briefly discuss some of the pros and cons and tips for building mental health tech. So a couple of the benefits include convenience and 24/7 service. Treatment can take place anytime, anywhere, and it could be ideal for those who have trouble with in-person appointments. It can be anonymous. People can seek treatment. Just back one slide, please. Without involving other people and sharing more than you feel comfortable with. It's an introduction to care. Tech could be a good first step for those who have avoided mental health care in the past, and there's a low barrier to entry. Lower cost. Some of these apps are free or low cost. Scalable and serves remote populations. Tech can help mental health providers offer treatment to people in remote areas or in sudden need, like after a national disaster or a national crisis. And consistency. Tech can offer the same kind of treatment program to all users and make it easy to continue support regularly. Now, a few of the drawbacks. Effectiveness. The biggest concern with tech interventions is obtaining scientific evidence that they actually work. In a 2019 study, researchers found that 64% of mental health apps claimed efficacy, although only 14% included any evidence. Privacy. Apps deal with extremely sensitive personal information, and sometimes developers aren't well versed enough with dealing with personally identifiable information properly. For whom or for what? Another concern is understanding if apps work for all people in all mental health conditions. There's a huge variability in how someone experiences mental health disorders, so a one-size-fits-all solution might not be helpful and in many instances be harmful. Regulation. The question of who will or should regulate mental health tech and the data it generates has not been answered, and this needs a lot of conversation and deep scrutiny. And last, overselling. There's some concern that an app or a program, if an app or a program promises more than it delivers, then someone might turn away from other more effective therapies. So last but not least, like I said, there is huge opportunity for tech to be leveraged for mental health. So a couple of things to keep in mind if you are thinking about building a mental health app or technology. First, educate yourself, define and engage with your intended audience. Before you get excited about the technical specs of your app, think about the disorder, the audience, learn more about them, go out and interview them and engage with them so you don't just build something that's a one-size-fits-all solution that isn't really helpful for anyone. 2, understand existing options in the healthcare industry and decide if your solution actually adds unique value. As I had mentioned previously, there's 20,000 apps in this space and a lot of work that's already been done. See if you can work with those existing initiatives and build on their work if there actually is an unmet need. 3, incorporate evidence-based practices. So it would be, of course, ideal if all of these apps and technologies were designed in collaboration with mental health professionals, but that's pretty far from reality. So make sure you're prioritizing the research and the evidence when you are building something. 4, be clear about the security risks and data privacy. If a mobile app is used incorrectly or insecurely, user information has a risk of exposure. This is something that should be taken more seriously than almost anything I said here. Remember that giving out someone's information might lead to consequences, not just now, but further down the line in their future and the kinds of things they want to do. And that privacy and confidentiality laws are different from state to state. 5, don't underestimate the impact of stigma. So despite all of this progress that we've talked about, there's still a lot of stigma that affects people's professional careers, insurance companies, and future employers. So consider how the app can be used discreetly in a place where there's option, so there's no sound, and even thinking about the branding so that it's clear enough to talk about the purposes, but it's indiscernible to others who might see their phone. And then lastly, apps and tech do not replace the need for therapy, in-person support and interaction, or medication. Many times tech is talked about as a silver bullet, but especially with mental health, it should only be seen as a way to support those that need it. So if you'd like to learn more about the Technology and Public Purpose Project, you can follow up at thebelfourcenter.org/tap on the last slide. There's the URL. And again, thank you for letting me join this conversation.
All right, thanks, Laura, for those words. Thank you so much, everyone, and I'm truly delighted to be here. As Aditi said, I am Colonel Merbin Caratini. I'm a National Security Fellow at Harvard Kennedy School. I'll complete the program this summer, and I will change stations to Germany as an active duty military, where I'll be in command of 7 healthcare facilities distributed across Europe. I want to spend a few minutes articulating what I'm trying to implement before I depart for Germany. There's no secret that we've been at war for over 20 years, many operational deployments across the world, and a military that has been dedicated to win our nation's war have led to a high level of stress among many soldiers. Large proportion of our soldiers develop mental health problems in service and afterwards, such as post-traumatic stress disorder, whether it's depression, uncontrolled anxiety, and addiction to controlled substances. The potential for suicide-related behaviors is high, and unfortunately, as leaders, we have experienced very close the intensity of it. I will share with you a short story, but it will change my perspective. It was a Monday a few years back. I was walking back to my office, and my phone rang. He was one of my captains. I said, "Hey, John, how are you?" He said, "I'm okay, sir." Paused, but I have some news. One of my soldiers died this weekend. We went back and forth asking who it was, what was he doing, to ultimately arrive to the most undesirable question. I asked him what happened. The captain said, "Sir, the soldier killed himself." I walked around my office for a couple hours in complete fog, trying to understand what had happened. Why I had just communicated with a soldier a few weeks earlier, and I had no idea that he was in trouble. I blame myself as a leader for not knowing that. I went in the process trying to figure out why and what's happening in the community. Why are these things going on? Well, to that end, we embarked to develop an approach that implement innovative solutions that enable the Army to achieve early identification of suicide-related behaviors and deploy effective interventions by trusted agents within the chain of command. There are 2 areas that we want to introduce. First, how do we innovatively leverage trusted team members for rapid interventions and operationalize in a way the Chief of Staff of the Army, My Squad, which is a new initiative that he is trying to establish. There's no secret that suicide continued to increase among our soldiers and in the population for over the last 20 years. Obviously, traditional methods of identifying soldiers at risk and providing behavioral health treatment when needed is not there. So we have to innovate and leverage technology to develop the solutions to this dire problem. Some research studies have found that we can accurately identify soldiers for suicide-related behaviors well before the time these behaviors occur using machine learning methods applied to electronically stored administrative data. We can also identify soldiers experiencing suicidal thoughts by leveraging machine learning methods applied to social media. We can improve risk identification using multimodal data from personal devices such as smartphones and wrist-worn biosensors such as Fitbits. Personalized outreach through smartphones increase the likelihood that at-risk people will seek help and engage with help once initiated. We propose the development of a workable system that has continuous quality improvement built into that allow leaders to identify and intervene with soldiers that are experiencing this risk. The necessary components include the data prediction, which is shown in the graph. Diverse data streams ensure the risk is identified across multiple real-time domains, which lead to a more accurate and timely prediction. We need a means of collecting, continually updating, and storing the input data. Not shown in the above figure, the data can be stored in a secure format behind an Army firewall that exceeds both healthcare and Army standards. We can have a training system that allows the prediction models to be developed, tested, and refined. The system will use transfer learning and type of machine learning that allows the system to predict individual risk by applying insights learned from the entire population and identify the risky patterns. And the last portion that I believe is so important, we have an implementation system that generates real-time predictions that dissects those predictions to look at decision makers and provide feedback to support the quality improvement method. As shown in the graph, there are many potential means to act on these insights. Whether it's self-help, whether it's team on the squad, whether it's medical help, we can leverage technology to be able to address those. There's a few challenges that are like any initiative that exist, and we're trying to address them. One is that the soldiers don't want to be closely monitored. So therefore, we have to leverage the technology for good. So how can we use wearables and so they can basically facilitate data streams and they can use them for wellness? There's pushback from those wanting to maintain the status quo of mental health assessments. The personalized nature of this approach will make care more accessible, more effective, and will be developed in collaboration with all the agencies to create a sense of shared engagement and to address the concerns that are raised by the Army and others. There's another concern that I think there's one of the most powerful, which is that personal electronic device use is not permitted in all areas in the military for security reasons. So our solution will be to have the ability to work in offline mode and not transmit data, be able to integrate with non-digital data collected during these times and employ the multi-model data collection. The way ahead, basically, we'll continue to try to establish the timelines associated to get the approval model so we can have the systematic approach to mental health and trying to predict the suicide behaviors. So hopefully by next summer, we'll be able to implement or have some sort of experimentation when I head to Germany. I've been delighted to be with you. I'm happy to look at questions during the Discord. Thank you.
Great. Thank you so much, Mayor. This is an incredibly important topic for everyone. And so if anybody has any suggestions or if they're willing to help build a proof of concept, please do reach out to Mayor on the Discord server. He'll be hanging out there. So let's continue the conversation there. We do have to keep going. I am very, very excited to introduce our next speaker, Grahame Grieve. I'm sure everyone in the digital health space knows exactly who Grahame is, but he really is the author of Principles of Healthcare Interoperability, this book right here that I'm holding up. It's really the seminal book, and I've read it several times, and I can tell you it's definitely very, very informative. He's the FHIR product director at HL7. Grahame is also the inventor of FHIR and the project lead of the FHIR core team. He travels all around the world, giving lectures and really helping people with the connect-a-thons. So I encourage you to really watch his talks on YouTube. He's got several of them. Without further ado, I'm going to bring him to the stage and let's give him a real warm welcome. Thank you, Grahame, for being with us here today.
Thank you, Aditi. It's a pleasure to be here.
Do you want me to share your slides, or would you like to share?
Yeah, that'd be great. Yeah.
Okay, I will need to find them. Just give me 1 second. So, Grahame, I actually don't have your slides. Do you want to share your screen?
I can do that, yes.
Okay, perfect.
All right. Can you see my screen?
Yeah, let me move you to the stage. There you go. And I'll go back. It's all you.
All right. Thanks, everybody. It's a pleasure to be here. I'm going to tell you about FHIR and a little bit about how and why we do what we do. I'm not going to talk so much about the standard itself. The FHIR was born nearly 10 years ago now. It seems like, well, both short and long time ago. And it was born out of a recognition, very personal thing for me, recognizing that the healthcare system that I know, that I experience both from a provider side, I was a scientist, not a doctor, but as a consumer, as an advisor to my family on health matters, is that our healthcare has broken processes. And what I know is that everybody runs their own little piece of the healthcare system at world class with as much efficiency and safety as they can. But people don't look at the overall system in the same way. And all these little pieces of excellence have gaps between them. And what I've experienced as a patient is that people fall into those gaps between the different care processes, and those gaps become chasms, and they lose significant amounts of wellness or even their life in those chasms. They don't even know what happened. They don't even recognize what went wrong. And so it's a significant limitation on our health and our wellness. This year, that's been wound up a bit. Aditi said, I travel the world. Well, not right now. That's been wound up further as, acute changes arrived to our lives and our system. But it hasn't changed the overall picture, which is that we could have better outcomes if we could have better consistency. And I look at a system around the world and I say, it doesn't really matter how you fund the system. It doesn't really matter how you manage the system. At the micro workflow level, the ways the system are broken are mostly the same all around the world. And we've seen that other industries are being transformed. They're being transformed by IT in really significant ways that really improved workflows, improved user experiences, improved outcomes are transforming and causing massive changes to the way those industries are experienced and provided. That's not happening in healthcare. And it's not happening in healthcare for lots of reasons. But one reason is that the IT standards to properly create the right workflows, to implement, to integrate business to business and consumer to business communications, they don't exist. The backbone with IT doesn't exist. And it's because the standards don't allow it. Now, there's lots and lots of things that are blocking change, that need to change if we're going to fix healthcare. And most of the others are more important than IT. But IT is a blocker for them, because even if you fix those other things, you still can't do the integration properly. And so I said, I want to take on the IT problem. I was well situated to do it, but I was, I recognized that HL7 wasn't going in the right direction, and it was either stop because it's not helping anymore, or do change the game. And for personal reasons, because I don't want to fall into those same gaps, I decided to change the game rather than walk away. So before I go on, I need to tell you a little bit about HL7. So HL7 is the organization that produces FHIR. FHIR is a product of HL7. And HL7 produces a set of healthcare data exchange standards that are widely used and much loved and much not loved, because, they're widely used. And FHIR is, like the latest generation product. And as a standard, we're trying to position FHIR to move the game to a new point. So what is FHIR? So it stands for Fast Health Interoperable Resources, but really it doesn't mean anything. And in fact, it's just an attempt to come up with a name that people remember and people can make jokes about. And it works pretty well for that. And so FHIR is two things. I think people focus on very much the product rather than the process. But for me, the process, the community is the most important thing. So it's a community that's dedicated to making it easier to exchange healthcare information using web infrastructure. And the community uses web infrastructure as open community. And so that's, for me, that's key. That's the real asset that we have. The community that is capable of developing standards that people want to use. And then the community produces, by, dint of a great deal of argument, a specification which we publish freely available on the web, so hl7.org/FHIR, which describes how to exchange information about healthcare and healthcare processes and health, and using web standard infrastructure to do so. And so it's like a snail in its shell. So open community and an open standard. Our goal as an open community is to make it easier to exchange healthcare information and to do so with open participation. So anybody can participate, and many thousands of people do. And what we produce is an open standard, which, although it's new tech and it's focused on being as current as possible at the technology level, at the same time, has deep continuity with existing healthcare standards. And that's one of the challenges with healthcare. People really care about keeping the existing process going and preserving their existing records. And there's a lot of overhead for doing so, but actually it's a really critical thing. We build the community and a product using an open process that's well documented and that's hopefully reproducible and that people believe in. And it's a really interesting property of what we do is that we produce open knowledge that everybody has and that everybody owns. And so big companies and small companies and governments come to us and bring us their best stuff, their best ideas, their best IP, and they give it to us so that everybody has it. Because if everybody has the knowledge, then they can depend on everybody having it and build businesses and build solutions out of it. And so what we actually build is community treasure that we all own, and we're all richer because we all own it. It's an interesting property of knowledge. And in order to build that foundation, we have solid governance backed by ANSI, who look over our shoulder and say, you've got to say what you do, you've got to do what you say, and then you've got to, document that you did. And so we meet in many different forums, in many different ways, to iterate on the idea and produce confidence that people's trust is rewarded by continuing to, broaden and add and deepen the specification. So in form, the specification is a web API to say use web techniques to exchange data between systems, and the API is a sort of general purpose API for exchanging information. And then we describe a set of modular content that's exchanged by the general purpose API. But we also recognize that the web API doesn't solve every problem. And so we talk about various ways to exchange to meet some of those problems that the web API doesn't solve out of the box. And then we provide a bunch of common infrastructure around how to make things happen. So from my point of view, if you're going to introduce a new standard and people are actually going to adopt it over their existing approach, which we really want it to happen, it needs to be better by an order of magnitude. an incremental improvement needs to be an incremental change. If you're going to actually, go back to scratch at the technology level, so that people have to re-implement, it really has to be worth their while. And so what are the things that really moves the needle a whole order of magnitude? So the web API is capability based. It's a great technology stack, and it gets a lot of focus, and it's justifiably a key part of the value proposition, but it's not all of it. We also wanted to make it possible to use a common content model across all your different exchanges. You don't want to have to recast information and translate at every step of the way, because it's a high tax overhead on a transaction. We want to reduce the transaction cost. The open license is key. Anybody can use what we have. You can release software, open source software. You can there's no like IP restrictions, and they're just more tax. Internally, our philosophy is very pragmatic. We try and keep the theory overhead, that's important, but health is not a consistent process. And so we try and follow what people actually do rather than forcing that to change. As I said, open community, anyone can participate. And we provide a bunch of public tooling and testing infrastructure so that people can actually check that their implementation lines up. I remember starting out doing my first V2 implementation, and the first implementation product that I could copy, that I could work with, had a bug in the V2 messages. So for years, my V2 messages had that same bug, until I ran into someone else who was incompatible with that. And that was our collective experience doing version 2 back before any of this public infrastructure existed. So those are some of the really big things that make FHIR worthwhile. So we've been doing FHIR for, it's 8 years now. And in that time, it's gone from a fringe interest of a few of us to pretty much the main focus for standards development, but not yet for actual implementation. That's in process now. And so the way FHIR works is that because the healthcare systems vary, from region to region, from state to state, from different disciplines. The way a GP thinks about data is very different to the way specialists do, institutions do. And you hear some of those underlying issues manifest into political challenges rather than technical challenges, because people don't really appreciate those differences. And so what we do, we can't define a single specification with all the rules in place. We'd love to do that, but it's just not the healthcare system that we have. So there's an international specification that derives an overall framework for how information is exchanged, but different regions and projects and vendors publish their own local adaptations to their requirements, and in the form of an implementation guide, which provides a bunch of computable assets around how we use FHIR for a particular problem. And then we have a bunch of tooling to produce and leverage the existence of those computable statements. So it's basically the standard provides its own reflection layer of the standard itself. And then that leverages into production in implementation systems. That's a whole layer of complexity that we wished we didn't have to have. But until there's a single centralized healthcare, no, that'll never happen. That will never happen. So to think about what we're doing with FHIR, we need to think about it in three different levels. We set out to transform healthcare IT standards themselves. And in the 8 years that we've been working, that's largely happened. We didn't just change FHIR. All of the other standards communities, which all provide value, all of them looked at the way that we were working as a community and said, We need to respond to that. And so all of the standards have become more pragmatic, more implementer focused, more open, and all of those things have improved the implementer experience. And if you want to introduce new healthcare standardization, and that there's a vast need for that at every level, FHIR doesn't solve all the problems. If you want to introduce new potential solutions to contribute to public knowledge, you have to be much more focused on outcomes and implementability. And so we regard those kind of changes as done. The changes that we've wrought are not yet complete, but they're inevitable, and everybody's, you know, in a race to get on that. And so the healthcare IT standards, publication process, and so forth leads to much better outcomes for implementers. Then I've got a typo here. Then we set it to transform healthcare IT itself, and so we really wanted to say your experience of working with healthcare IT products is better, and the key is that on the left is the way people used to develop software. They would create a walled garden with a bunch of componentry that they provided, as a vendor would provide, and then they would create the black diamonds, integration points on the perimeter of their walled garden, and that it wasn't like a business choice, it was a technical necessity. That's how we knew how to do integration. That's the products I used to work with, 10, 15 years ago. They were built from scratch like that, and within the walled garden, information was pretty fragile. Workflows were, internal workflows to the vendor. And if you wanted an external workflow, you would build a specific interface using version 2 or a text file or something like that. And you would create business function specific interfaces that were, their own relatively fragile, and each one would be associated with contracts and maintenance and testing, and they're effectively bespoke. And now what we're doing is we're migrating towards the second model on the right, where you have a single coherent core system that provides a set of APIs, mostly, but not always, based on FHIR, and all of the componentry that you provide, whether it's user interfaces or background services that move information around, all of them use the same common documented, resilient, tested, and testable API. And that can be orchestrated on, and so you've re-architected your internals so that interoperability is an inherent part of the system. Everything that you use is documented for anybody else to use, and in some ways it's not really technically different, but it's a different way of thinking about how you achieve what you achieve, and it wasn't something that was possible in the past. It's not something that's easy to retrofit into existing systems. But it's a transformation that we're seeing and that we're helping to drive. There's lots of other reasons for it to happen. And it's a transformation that leads to, sustained change in not only the technical products, but the business around the products, and then the outcomes of using the products. From my point of view, a key thing is this is economics. FHIR makes things easier and faster. We reuse technology and community that are widely available, skills and libraries. Everybody does things this way now. And now the FHIR community is active and open with better APIs and solid tooling. And those things drive down the cost of implementation. When I said we said we wanted to reduce the cost by an order of magnitude, a 90% reduction in cost. And people laughed at me, but here's how it works. So when we started out, to connect up an institution to a personal health record was the total cost of ownership. By the time we did sales and contracting and maintenance and legal fees and actual development, which was just a fraction of the cost, we kind of figured there was a TCO of 150,000 US for a 10-year implementation. And now, if you want to sign up your hospital to Apple, that's free. You sign up, you register the test, you provide the you connect up to your API that you set up with your vendor. Bingo, done. So the cost hasn't gone away, but it's been dispersed, and the actual transaction cost is, well, officially free, but you still got to do the work. So in effect, we really did achieve that kind of 90% reduction in the cost. And then what that does is it makes it easier to get a bang for the buck that you spend on integration, easier to get benefits, more willing to spend money to get those benefits. And so what we wanted to do is to empower applications to offer more functionality at less cost and to drive them to be interoperable at core. And one of the ways we do that is by shipping a bunch of open source software that provides modular capabilities in this space. And the thing is, you can't compete with open source by reducing cost. You can only compete with open source by offering a better product. And so open source is kind of the floor of the market. Below, if you provide less functionality than open source, well, you've got a problem because open source is free. And so one of the things that we do is float the market, as it were, to force it towards better functionality. And the goal then is to transform healthcare IT. And it's starting to have a notable effect. It's not by any means done. It's not by any means a completed process. Most of the products in the market today still very much look like those walled gardens. And the experience of healthcare institutions is still very much bespoke integrations. You can't focus that way. I tried to run a vendor for many years before I was doing FHIR, and the appetite for integration vastly exceeded our ability to deliver in any economically rational sense, and it's a doomed formula. And I'm happy that I did my own bit to doom it, but the change is not quick. So it's happening. And eventually that may lead to some changes in the actual market of the big EHR vendors. Maybe they'll do better. Maybe someone else will do better. I'm not really fussed about that. I want change at the micro level. The other thing we want to do is we want to transform healthcare. But that is just beginning. We're by no means seeing that outcome, but that's where the focus has moved to for us, is changing healthcare. And I started at the beginning with the observation there's gaps in healthcare processes. The clinical processes are disconnected, and they're typically disconnected at governance boundaries. A team will govern itself and choose its own processes, and they'll work really well. Most of the failures then are moved to the edges of those processes. And almost always they're tied to the physical boundaries of the institution in which the team works, or sometimes smaller or larger organizational boundaries. It's usually where they assess their quality measures that represents basically, you basically push all of your problems out to the boundaries, and then you can not count them. And there's all sorts of reasons why that happens, and it's not appropriate to change that, and it would be very costly to try. But what we really want to do is to allow deep integration of workflows across those boundaries. And IT is a critical part of that step. But of course, if you know the healthcare system, you know that IT is not going to solve the problem. And when we've never thought that IT itself will solve the problem, it just enables people who want to solve the problem, who can actually do it. And that means clinical champions to drive clinical process change depending on the solutions that are not yet in place, but we're currently building. And this leads to a common frustration of patients just about every patient I know has experienced this. You go to a GP, the GP sends you to a specialist, the specialist puts you on a treatment, you go back to the GP, and the GP says, that's not the right treatment for you, do something different. And then the patient is left trying to decide which of the medical specialists is the right one for them. So this is a bad process, particularly in mental health, very destructive. I've experienced that with a number of, care processes around mental health. And so conflicting care plans, scheduling problems, payment problems, even conflicting definitions of what success is. This is not a way to serve the patient. So we're focused on creating services to establish and enable distributed care plans, virtual clinical review. It's an investment up front for a healthcare system to transform to that model. And it's really hard to convince clinical people that that investment will pay off, because there's a bunch of consistent activities that are needed, and good governance and management to actually bring them home and make them worthwhile, rather than simply another tax. And so this is, something we can enable, but it's not yet enabled. But for me, this is where the real value proposition of what we're doing is. So FHIR disrupts healthcare and healthcare IT. We want to encourage the development of an open community that creates community treasure and community infrastructure, and that iterates us towards what sometimes is called Health 2.0. And as I said, FHIR is just a small part of that overall process, but we think a critical enabling component. But what I want to appeal to you all today, the whole concept of civil society is under threat. That's become more evident over the last year or two, but it goes much further back. I wrote this slide, many years ago. Civil society is the foundation of what we have, and it's built by people who contribute their knowledge and their passion to the civil society around them. And so I encourage all of you to spend a few hours each week contributing to some open community that creates community treasure in knowledge and make the world a better place in a meaningful way. And it's that builds, the solutions that solve the problems in our lives. So thank you very much for listening, and I hope you enjoy this event and get more involved in some open community around you. You're on mute, Aditi. I can't hear you, Aditi.
Thank you so much. I know it's the middle of the night in New Zealand, so I really appreciate you staying up for us. There are a lot of questions for you on the Discord server, but I hope you can just answer one, and then the rest we can continue the conversation throughout the week. I've got some FHIR mentors available to answer the more specific questions that the participants have. The one question comes from Brian Wang. He wants to ask you how much of FHIR's adoption depends on large companies like Cerner to fully embrace it. Do they have the incentive to do so?
Well, I mean, those companies are significant players in the marketplace of IT functionality in healthcare, and so adoption significantly depends on them for that reason. Those companies are highly motivated to share patient data. It doesn't always manifest into their customers' experience, because the big companies that have lots and lots of competing priorities, but at the engineering level that I work with, they're highly motivated to do so. They're also highly motivated to recover cost and make a profit, and that doesn't always, that creates its own issues in the market. But I think in the long term, all those companies recognize that the big picture trends that I talked about are happening. FHIR is just a part of those big trends. And if they don't stay ahead of the curve, the market, then eventually creative destruction will come their way. And so investing in better IT, better infrastructure is key. So I think the market, my feedback from the market is people are frustrated at how slowly they are moving, but they are moving, and they're moving as quickly as they know how to. And I look at that as a business thing, not just a technology thing. At a technical level, sure, you could move quicker if you could, just abandon sways of your product. So it's kind of a mixed answer, right? It's in progress, but it's not progress as fast as we would like to bring the changes we would like as quickly as we can.
Yeah, no, great answer. Thank you again, Grahame. I know it's the middle of the night for you, so you have no idea how much I appreciate it. I will have other FHIR mentors to answer some of the more specific questions that are being asked on Discord. So thanks again. And I encourage all of our viewers to go watch Grahame's YouTube talks. He travels literally all over the world, or used to travel all over the world when we could. So there are a ton of talks on YouTube with Grahame in them. So, all right, thank you so much, Grahame. All right, so that actually wraps up day one of our Tech Talks. Tomorrow, we're going to kick off with the one and only Dr. Ken Mandel from Boston Children's Hospital, and that'll be followed by Dr. Ricky Bloomfield and the Apple Health team. Just a quick note about tomorrow's talks, they will not be available for later viewing. So if you want to watch them, you have to attend the live stream, and you should have received the live stream link only if you registered for this event. So let's continue the conversation. I'm going to be signing off YouTube Live for now, but I'll be hanging out in Discord throughout the day. So feel free to directly message me on Discord with your feedback, because I do want to make sure that all of these talks are useful for you, and I want to make sure that you're really set up for success. All right, thanks again, everybody. See you tomorrow. Bye.